All doctors are also teachers. It is not always that they should be in a teaching hospital where they teach students, or they should be in a corporate hospital and teach students. All doctors will be teaching their junior staff. All doctors will be teaching their nurses and nursing attendants who are working with them. And most importantly, all doctors will be teaching their patients also about what to do, about what the treatment is going to be, what is the nature of their problem. All this is going to be taught to the patients by the doctors. So it is important to develop teaching skills. But how is medical or surgical education different from other types of education and teaching? Medical education is a type of adult education. We cannot use the same techniques applied in the primary schools because that teaching is different. Medical and surgical teaching is a different ball game altogether, and I am going to concentrate mainly on surgical teaching in this video. As far as surgical teaching is concerned, as I have already said, it's a type of adult learning, and Kolb's theory of adult learning is very relevant here. It is known as the experiential learning theory. According to this theory, adult learning is a process where knowledge is created through the transformation of experience. So it emphasizes that learning is not just about acquiring information, but also actively engaging with and reflecting on experiences, because the student here is an adult. So the theory identifies four stages in the learning cycle: concrete experience, reflective observation, abstract conceptualization, and active experimentation. Concrete experience involves engaging in a new experience or situation. It's actually the doing part of the learning where individuals are actively involved in a task or activity. For instance, if the surgical teacher asks the student to assist him at surgery, this is an active part of learning. After the experience, the students reflect on what happened, analyze their feelings and reactions, and consider what they learned from the experience. This is reflective observation. Then, based on their observations, students form abstract concepts and theories. They try to understand the broader principles and ideas related to the experience. Finally, the students test their new understanding by applying it to new situations. They have already learned the surgical procedure from their teacher by assisting him or her. Now they experiment with what they have learned, making adjustments and further refining their knowledge and skills. But when a surgical procedure is taught to a resident or a group of residents, all of them do not learn in the same way. Kolb says that there are four learning styles, and we need to understand these styles as teachers because that is how the student is going to learn. The first is the diverging style. So students with the diverging style learn best through concrete experience and reflective observation. They are imaginative and enjoy brainstorming. Some students have an assimilating style. This style involves reflective observation and abstract conceptualization. Assimilators prefer logical approaches and are good at understanding abstract concepts. Some students are convergers. They learn best through abstract conceptualization and active experimentation. They are practical and enjoy problem solving. And some are what are known as accommodators. They learn best through concrete experience and active experimentation. They are hands-on learners who enjoy taking risks and adapting to new situations. So we need to understand that surgical residents are of different types. They learn in different styles. But as a teacher, we need to understand how each resident learns. So the summary of understanding of adult learning or adult surgical learning is that adults learn best when they are actively involved in the learning process. They can relate to the learning to their own experiences and prior knowledge. when they can see the relevance and practical application of what they are learning, and they have opportunities to reflect on their learning and make adjustments. Having said that, the role of the teacher is to stick to the principles of medical education and surgical education teaching. I have adapted most of the points in this video from the American Academy of Orthopedic Surgeons Educators course. The first principle is what is learned is more important than what is taught. That is because teaching involves much more than just telling. An example is when a teacher spends considerable time explaining a concept to a resident. 2 weeks later, as the teacher watches the resident respond to someone else's question, the teacher realizes that the resident has no real understanding of the concept that had been so patiently explained only 2 weeks earlier. So, as a medical teacher, we need to recognize that residents will not necessarily learn everything that we teach them or show them. So, what is ultimately important is what the resident learns. But why don't residents retain everything that we tell them? We told them so many points. Here, there are some possible explanations. Either we explained too quickly or used terms that the resident did not fully understand. The second is the resident initially understood but forgot over time because he or she did not have the time or opportunity or discipline to reflect on or practice what was taught. Therefore, the memory did not move from short-term memory to long-term memory, or the resident was too tired or distracted to fully understand what you were trying to teach him or her. As teachers, we need to be alert to what the residents are actually learning, not just what we are trying to teach them. Secondly, we need to use non-threatening questions to probe for understanding of the concepts that we have explained. We also need to provide our residents with strategies for long-term retention of concepts and information. Asking them to write everything down in a logbook is one of these concepts. We need to teach concepts and principles rather than isolated facts. And we always need to revisit important concepts to ensure that our residents have an accurate understanding. The next important fact is that residents learn best within their zone of development. A teaching that focuses on what the residents already know is not helpful, and teaching well beyond the residents' knowledge or skill level also is not helpful because it limits learning. For example, if you have a chief resident and a junior resident with you and you are explaining a concept to the junior resident, the chief resident sits patiently but is obviously bored. Or you are lecturing to the third year resident on a topic you believe is very basic. After 10 minutes, many students will have a glazed look in their eyes and it's clear they don't understand most of what you're saying. Every single resident brings prior knowledge and skills to each teaching situation. And background knowledge and skills can vary widely between students and residents and not necessarily in proportion to the person's year in training. So, to actually understand and deliver good education, the teacher must identify what the learners already know and can do. So, teaching should be directed to the learner's zone of development, the difference between what they understand and what they can do without you, and what they understand and can do with your guidance. It is important to foster active engagement rather than passive observation. Active means engaged in the work intellectually and physically. Too much observation and too little engagement will lead to less learning. For example, the resident may mention that he does not learn much during grand round presentations, especially when he is post call. Or one of the residents reports that he finds it very helpful to draw a series of diagrams outlining each new operation that he has witnessed. This is active engagement. Educational strategies such as problem-based learning are designed to take advantage of the benefits of active learning. So, As a surgical teacher, it is important to physically involve our residents in the learning environment. We need to strive to actively involve the residents in surgery even when they are not operating, like writing the summary notes, drawing diagrams, or repeating the details of the surgical procedure to his junior in front of the teacher. Another point to remember is that cognitive overload interferes with learning. That is because short term memory is limited to 7 plus or minus 2 discrete bits of information. That is all there that could be in short term memory. But a few key points can also be anchors for several other points. It's not a coincidence that there are 7 wonders of the world and 7 deadly sins. The typical person can retain only 7 discrete bits of information, maybe plus or minus 2 bits, in short term memory. So, to retain more information, the brain employs various cognitive strategies like rehearsal, visualizing, etc. Many students already have adequate methods of organizing information, but they still struggle with new information. Effective surgical educators need to be careful not to overload residents and students with information that may be familiar to the teacher but is new to them. So, when teaching, we need to present new information in a clearly organized manner. Teaching is more often effective when it is done in context because the learner can tie the new information to the realities of the context. This is where teaching in the outpatient department or teaching with the patient will be more effective. And when delivering new information, we need to pace the delivery so as not to overwhelm the learner. In fact, less information can provide more learning. The learning also depends on the environment. Embarrassment and threat can diminish learning. Excessive anxiety reduces the ability to process information. And always we need to remember when there are different levels of residence, first year, second year, third year, and so on, we need to question up the ladder. Because if you're going to ask the question first to the senior-most person and he is not able to answer, it becomes an embarrassing situation. Residents may forget what you said, but they will never forget how you made them feel. Emotions and cognition are interactive. As a result, a negative learning environment, for whatever reason, is likely to have adverse effects on a resident's ability to process, synthesize, and retain information. Learning requires a receptive mind. Negative emotions interfere with cognitive functioning. So, student learning is better in a positive learning environment. By making the learning environment positive and non-threatening for residents, will help them to push themselves to their limits. Students learn from a hidden curriculum. Now, what does that mean? What you do teaches more than what you say, and you are not your resident's only teacher in these modern days. During a tense moment in the operation theatre, when the surgeon explodes in anger, swearing and shouting at one of the nurses, the resident is bound to do the same thing a week later when he or she is performing a procedure. A large amount of learning during residency training occurs through a process of socialization. Residents observe how people speak to each other, how authority is expressed, and how things are done, and by whom. They quickly see what is acceptable and what is not, irrespective of what you say as a teacher. As teaching surgeons, it is critical to realize that what we do and how we act is probably more important than what we say. Our actions speak louder than our words. We need to capitalize on the learning potential, and we also need to remember, and we should emphasize this, that the residents should learn from other physicians, nurses, patients, and even equipment. So, as a surgical teacher, you are a role model. Avoid negative actions and negative language. Create a work environment that your residents will want to emulate. The hidden curriculum is hidden from you but not from residents.